Ankle fractures case discussion. A 50-year-old male presents with persistent pain and instability in his left ankle, 8 months after sustaining a medial malleolar fracture during a low-energy fall. He was initially managed conservatively with immobilization and a cast for 6 weeks. Despite adhering to non-weight-bearing protocols, he reports ongoing symptoms of pain during walking, swelling, and a feeling of ankle instability. Radiographs show a visible gap at the fracture site with sclerotic edges, suggestive of non-union. The surrounding joint shows early signs of arthritis. Blood tests reveal no evidence of infection. Patient has normal ESR, CRP, and WBC counts. The patient is a smoker and has a history of poorly controlled hypertension. Key considerations: etiology of non-union in medial malleolar fractures. Inadequate immobilization, insufficient stabilization leads to micromotion at the fracture site. Poor vascularity, the medial malleolus has limited blood supply, increasing the risk of non-union. Patient factors: smoking, poor compliance, and systemic illnesses, for example, diabetes, impair bone healing. Clinical presentation of non-union: persistent pain, instability, and swelling. Difficulty bearing weight. Crepitus or grinding sensation during joint movement. Radiographic features of non-union: persistent fracture line, sclerotic bone ends, lack of callus formation. Management of medial malleolar non-union: surgical approach, open reduction and internal fixation with bone grafting to promote healing. Adjuvant therapy: address modifiable risk factors such as smoking cessation and nutritional optimization. Post-surgical rehabilitation: gradual weight bearing with physiotherapy. Possible Viva questions and answers. What is non-union, and how is it classified? Non-union is the failure of a fracture to heal within the expected time frame, which is usually 6 to 9 months. Types: hypertrophic, which has adequate blood supply but inadequate stability. Atrophic, which has poor blood supply and biological activity. Why is the medial malleolus prone to non-union? Limited vascular supply and high stress at the fracture site contribute to the risk of non-union. What are the risk factors for non-union? Systemic: smoking, diabetes, malnutrition, and certain medications, for example steroids. Local: poor fracture immobilization, infection, or soft tissue compromise. How is a medial malleolar non-union diagnosed? Clinically: persistent pain, swelling, and instability. Radiographically: persistent fracture line, sclerotic bone ends, and absence of callus formation. What surgical options are available for medial malleolar non-union? Open reduction and internal fixation with bone grafting. Fixation methods: screws, tension band wiring, or plates, depending on fragment size and quality. What is the role of bone grafting in non-union management? Bone grafting provides structural support, promotes osteogenesis, and enhances biological healing. What complications can arise if a medial malleolar non-union is untreated? Chronic pain, progressive ankle instability, secondary arthritis, and deformity. How does smoking affect fracture healing? Smoking impairs angiogenesis, reduces oxygen delivery to the fracture site, and inhibits osteoblast activity, all of which delay healing. What imaging modalities can aid in diagnosing non-union? Radiographs identify fracture gaps and sclerosis. CT provides detailed assessment of bone healing and non-union characteristics. MRI assesses soft tissue and vascularity, ruling out avascular necrosis. How would you counsel this patient preoperatively? Explain the need for surgery to restore function and reduce pain. Discuss the importance of smoking cessation, glycemic control, and compliance with post-operative rehabilitation to optimize outcomes.